And I also hope, and Laura, you can write and let me know that you can also see my screen as I move from page 1 to page 2 about today's webinar. You now have the call in, and to I see some typing happening. We can see it. Perfect. Okay, so to ask a question, there should be a functionality tab. Laura will write it in the chat box where you can ask a question, and I can unmute you, and then you can speak, and we can have a great conversation that way. And so while she's writing that note to the people on the call, this will be how you can we can make this a bit more interactive. So thank you very much for participating. Let me tell you a little bit about the Integrated Care Leadership Network. It is a 501c3 charitable nonprofit focused on leadership development and the empowerment of clinicians and patients. Additionally, we provide education, training, seminars in order to promote ideas and affect change in healthcare. This particular webinar is being underwritten by the Moore Foundation, and some of you may know them, and we received a grant to take the knowledge that we've learned over the last many years in change management and implementing improvement in hospitals and health systems. And the grant was to put this into a series of workshops and webinars so that we could share that and disseminate that with everyone else, so you could also then take lessons learned and use them in your own facility. So while our nonprofit is called the Integrated Care Leadership Network, the program that was initially started to improve sepsis mortality and medication errors in the San Francisco Bay Area with 9 hospitals in each collaborative was called the Integrated Nurse Leadership Program, INLP. And the INLP mission in theory of change was to transform the hospital work environment by developing nurses' professionalism in order to create and lead sustainable systems change. So everything that we did and all of the workshops, the trainings, the improvement was geared towards ensuring that really the chassis or the engine was developing frontline professionals' capabilities and capacities in order to lead any systems change. And this is the curricular framework that we use, and I'll say a bit about it in one moment. And just so everyone on the call knows, I shouldn't be talking for more than maybe 20 or 30 minutes from this point forward, and after that, hopefully there'll be time and interest for you all to share your thoughts and comments. And if you have thoughts and comments prior to the end of this presentation, feel free to raise your hand, ask a question, and then I'll be able to unmute you. So the curricular framework was the way that we thought about those, myself and others who led this project, again, 9 hospitals at a time in a big Bay Area region, to improve specific outcomes. The way we thought about that was through a curricular framework. And as you can see here at the top, that curricular framework always comprised of 4 main components, where you have individual, team, culture, and process, which we felt drove to outcomes. And so under team domain had to do with understanding self and self-development, because wherever you go, you follow yourself, and you lead your own work, and you lead your work within a team, but in a collaborative environment. And so there has to be some self-awareness. The team has to be high-performing. It has to be highly collaborative, and there's a lot of technical skills and training that goes around developing high-performing teams. Culture, we focused on the culture of safety as well as organizational culture in terms of stakeholder assessment, understanding power dynamics and who influenced whom, so that we could actually drive improvement activities forward. And then the process is really the technical skills, tools, knowledge management of science of improvement around whether it's lean or model for improvement, that you're using data to inform decision making, and that if you focus your attention on these 4 areas, you can then drive towards very concrete outcomes. When here, this is a general framework, so it'd be whatever clinical process that you would put into that outcome. And we had measurements around professional nursing efficacy, team competencies, project management skills, and culture of safety. And at the bottom of this slide, you can see specifically with sepsis and medication, these were the 2 big projects that we spent about a year and a half on for each of those. The first bucket in red on the left is the Regional Nurse Network, and that was a professional forum to generally learn and skills around change management and to create a peer sharing network. And this RN2 is now largely included in and has become the Integrated Care Leadership Network, this 501c3 that's hosting this educational forum today. As we go on, this curriculum map, as I've been expressing, was broken out into these educational domains. And so each one of those previous domains under individual, team, culture, and process had an educational domain that mapped to it so that we could actually teach to it. And you can see here, these are the way those domains mapped out. So we were able to teach communication skills, leadership skills, team building, project management, managing change, and quality improvement. And as you can imagine, this was a big piece of the work to develop the framework and then to map it into a number of training sessions and then to measure that, whether we were being effective in teaching what we were planning to teach and whether that itself kind of linked up to improving, leading to improvement in our model of our theory of change. The way I see the role of frontline clinicians, and by background, I haven't said anything by myself about myself. By background, I'm a nurse, and I've studied improvement, change, learning organizations, not learning organizations, and so come by way of being a clinician who worked in pediatrics and emergency medicine for a number of years. And so just by background. And so the way I see the role of frontline clinician, whether you're a nurse, physician, or administrator, is that, which isn't front line, so it'd be nurse, physician, pharmacist, et cetera, is that we tend to be underutilized as the ideally positioned healthcare provider to turn an organization into a learning organization. And so that was, again, another underpinning of how we got the work done was by appreciating this under-leveraged asset, if you will, which frontline clinicians in driving change. And so all the work you're going to see in this webinar and in the future webinars where we go into deeper dives on this was all driven by nurses and physicians, pharmacists, respiratory therapists, people who typically don't spend their days doing improvement work. They do patient care. So you don't have to be a specialist. You just have to have time and attention and focus. Why hospitals tend not to be learning organizations is that even though we are in the best position to provide key insights, we're pretty much not valued for those key insights. The people that we might provide suggestions for improvement to, so that those that we would pass on our ideas may not be in a position themselves to actually make improvement, or they may not appreciate that it's the small concerns that might be considered petty are actually the daily grind of improvement that needs to be done because, as you know, improvement is done step by step, not by leaps and bounds. So the first grant was focused on improving medication errors by 50% within 18 months. We focused on the emergency department, ICU, TCU, medical surgeons, so essentially all areas of the hospital. And as I've been saying, we focus on improving frontline processes, specifically systems-driven and set processes, which I'm going to talk about in a minute. The second grant, just to give you a high level here for what we focused on and what this change framework addresses, the second grant focused on improving mortality rates from sepsis through early recognition, again, hospital-wide, and that aim statement had to do with improving sepsis mortality by 15% within 18 months. In fact, we ended up improving sepsis mortality by 56% in 18 months, and in the other grant, we exceeded our outcome goals as well. And the process goals had to do with use of a screening tool 95% of the time, and use of the bundle, pretty much the entire bundle minus the central line 85% of the time. The timeline, as I've been talking about, 18 months, we're now going back in time. You can see these actual months and the main milestones on what we did here. We had a measurement system. We used the CalNOC tool for medication administration tracking, which is a naive observation format. We assembled teams, steering committees. We gathered baseline measurement on all units so that we could determine improvement over time. A few months later, we had our first kickoff, and we had several training days over the course of these 18 months. That kickoff, we reviewed the data at all unit levels so everyone could see how they were performing and opportunities for improvement and which areas they wanted to focus on first. And then a year and a half later, we did final measurement and then developed a sustainability plan. For sepsis, sorry, some of the line formatting is funny. It was essentially same kind of format. Again, collecting baseline, getting your team, identifying your targets, collecting baseline data, doing training, and then at the end, doing your final data submission with sustainability plan. Nothing really surprising here. It's just everything was very, very articulated so everyone knew what they were going in for. Now, as you know, for those of you that do improvement work, that the issue isn't whatever the issue is. You can fill in the gap, whether it's medication errors or sepsis, mortality rates. The real issue is change and getting people to be comfortable with that. And as we know, every system is perfectly designed to get the results that it gets, which means inadequate systems produce inadequate results, which is why we focused on producing reliable systems and processes and appreciating that then the outcome we wanted would follow. The reason we focus on processes is because, as you know, mistakes up. So the probability of success with 95%, if you have one step in a process, which never happens, then you have 95% reliability, 25 steps in a process, and now all of a sudden your probability of success getting exactly the outcome that you wanted starts to fail miserably. So really focusing on the steps that drive to the outcome is where we spent our time and our effort. This comes from the Swiss cheese, James Reason's Swiss cheese model of harm, which is that poorly designed systems and inadequacies in the line build up, and you end up with these holes, if you will, in steps along the way, and you create opportunities for error and failure points. Our reliable formula for change, as I've been hinting at, had to do with frontline leadership, executive and physician sponsorship, and using evidence-based practice that then led to our improvement. So again, focusing on system steps. So let me break this down a little bit. What will drive success in your organization? So focusing on evidence-based practice. I think we all know that. but not allowing kind of an opt-in culture to proven practices. I work with a lot of hospitals and health systems. I see this all the time, whether it's sepsis, which is fairly well articulated, or any other kind of care pathway. Either people don't have them, they have them, they don't use them, they use them irregularly. So it's not systematic and it's not rigorous, and the data aren't evaluated at a level where you can really understand outliers, both for positive deviation and deviance and negative deviation. So this is really at the crux of a lot of the work that we're talking about today. The frontline leadership involves training people so they understand process redesign, data management, communications, and change management. And so, again, it's evidenced before in the curricular domains. These were, when we had off-site trainings, when we do webinars, these were the areas that we focused on so people could understand the importance of what process redesign and standard work look like, what flow charts look like and how you use them, how to use data, what strategic communication, branding, program development skills is very, very important, even though you might not think so. And then change management is really around organization influence. The executive sponsorship, whether it's physician and or other executives, really is very, very important. And I'd have to say it becomes the most important component in any improvement activities. If the physicians and the executives aren't on board and you don't have clear sponsorship, then it will become excessively difficult to drive transformation beyond the pilot unit or the pilot activity. And again, that's the formula for change. The framework that we've used when we're talking about rolling out, setting up the processes, you have a core resource team, which is also a steering committee. These are people who have some influence in the hospital, formal influence in the hospital. You have people who understand data. You have a good mix of disciplines. And then at each unit that's involved in the project, you have project teams. So you have frontline clinicians involved at the unit level because that's where the actual change takes place. And so over the period of the 18 or 20 months, you have planning, you have the pilot. So all of these programs started with piloting, usually on 2 units. We typically started in a medical surgical unit, and then, or with sepsis, we started in the ED and then to the ICU, and then put it into the med-surg units, and then rolled out throughout the rest of the hospital or the health system, and then spent time embedding, which is equally as important because, as you know, backsliding can happen very, very quickly. This is a breakdown of the steps where you identify the problem, which would be your baseline data. You're doing your tests of change. You're implementing your trialing. So you're moving through innovation, implementation, systemizing, and disseminating. And we would iterate that many, many, many times. Sometimes that took a week. Sometimes that took a month. But coming up with that solution for that unit doesn't always translate into another unit, so you have to go through this process again and again and again. So with medication error reduction specifically, again, I mentioned these were our goals. Using this James Reason Swiss cheese, we identified what the issues were for our process flow map, and as you can see here, it's these are some of the failure points. They're not all the failure points, but often we would see nurses didn't check the medication against the record. Nurses were distracted or interrupted. Labeling, mislabeling from the time of removing the medications from the package to the patient was also an issue. Not checking 2 forms of identification, and then not charting the medication immediately after administering. So oftentimes you have, for this error, what you would see is duplication sometimes, and so double dosing the patient. So these were a couple of the medication errors that we encountered. The project, as I've mentioned, here, I think this is going through some of the activity I've just mentioned. So I'm going to skip this. The data sample, as I mentioned, we used the Cal-Naive observer form. We obtained 100 doses at baseline and at the end or the close of the project. And then every month, on every unit, we also collected a sample of 20 doses. So that way, we could continuously understand how we were performing. The errors that we captured, so the process errors were these. So we checked these through a naive observation. These were process checks. And the error types we captured through reconciling against the medical record. So we had observable data, and then we had the medical record data. And then we also added in errors of omission or that the medication was not available. And so that was the way that we were able to capture the data and be able to track it over time. We also did a cost of errors calculation so that we could understand and use as influencing conversations to those around us and specific stakeholders who might be interested in other aspects of safety rather than the patient harm dimension. So having a cost of an error and doing a business case around that was another activity that we did. As I'm going to talk about more of the techniques for tracking and improving in the next seminar, but this one I wanted to show an example of how we focused, most of the teams focused on reducing distractions that occurred during medication error reduction, medication pass time. And so you can see here, this is an annotated run chart over time. The test of change is TOC. You can see that staff education were a couple tests of change, awareness campaign, overhead announcements, and logging. So these are results based on after 10 medication administration passes. So these were their tests of change. And then we measured each hospital. We had a dashboard. They had a dashboard, and we created a master dashboard, if you will. So here the CRT is the steering committee, the units. We had all the units for the hospital and for the entire cohort. Again, you can see these are the mini observations, which are the 10 to 20 observations per month, how we did with process measures. And then the other thing that we measured is the other drivers of what creates change is whether tests of change were being done. You can see there towards the bottom half of this slide, whether the team that was working on the improvement met at least twice a month, whether you had at least half the team attend, whether you had the appropriate measure set, and whether the data are improving, and whether they were completing these activities. So you can see the medication. So again, these are the process measures. You can see how from month to month we would go up and we would go down. And we were not at that. Some hospitals were a little bit more reliable, but we tracked this for many months ongoing. And then here you see a standard run chart of checking 2 forms of ID. Again, just other visuals to be able to understand performance in a month-by-month basis. With sepsis mortality, it's going to be very similar, except, of course, we have different dimensions of measurement. This is arguably a more complicated, complex activity to improve. Again, mapping this onto this Swiss cheese model. There are any number of issues in sepsis, lack of buy-in for the early goal-directed therapy approach, this tendency to eyeball it. There is not one physician expert. You have all kinds of physicians often thinking that they know what to do, and so you see a great deal of variability there. Testing delayed or not ordered. Drugs or antimicrobials not available in PICSIS, poor communication, trying to migrate not only the care activities, but the time lags between the care activities, and then a lack of standardization to escalate these, to perform the interventions, or when patients are transferred from, migrated from, say, the ED to the floor, and then activities are sometimes just lost or seriously delayed. Again, this was a grant requirement. The program structure was the same. We had that core resource team, which is also, some people call steering committee. Again, unit-based teams. We had off-site trainings. We had, in between the off-site trainings, we also had basically homework so that we wouldn't go too long with anyone without real improvement being done. And this could be writing emails to important members, developing communication strategies. It was any number of kind of activities to try to keep driving the change forward. And if you're thinking to yourself, well, this sounds like a lot of work, there's no way we can do that, I would counter-propose. There's no way not to do this kind of effort and try to get results that you'd like to see. So I think I've showed this before. With the overview for sepsis, again, we had about the same time horizon, 18 to 22 months. We had 4 core strategies. We had seminars or trainings. We did education, of course. We implemented the sepsis bundle, and then we looked at coded data. So this is, again, I think very common approach. I think the interesting thing that we brought was just a high degree of formalization of our implementation. We also used, this is how we identified the coded data. We had an expanded set of ICD-9 codes, so that was how we understood the outcome mortality. We looked at that every 6 months. And then in between, every month we used the actual clinical data and patients who presented and met the criteria for SEERS. And then if they had an elevated lactate or were hypotensive, then they became clinically also in our bucket for entry to compliance to the bundle. We did have some exclusion criteria like comfort care, et cetera. But otherwise, if you rang the bell, clinically speaking, for hitting the criteria for being septic, you were in our database, and then we evaluated that for process measures. Again, the outcome measures were done by the ICD-9 codes. We also collected the other data, as I mentioned and showed you before, around meeting attendance, completing test of change, holding unit-based meetings where people showed up, as well as the steering committee meetings. We did a cost analysis. Also, as you know, sepsis is expensive and becoming more expensive, and now is a CMS measure set. So this becomes just increasing focus. And I spoke fast. I didn't mean to. And so I'm going to pause now. As I mentioned throughout the talk, there will be 3 other presentations where we're going to go into a great more detail around exactly what was done for each one of these 2 activities or collaborative. This is meant to be a high-level overview, and I would be very interested to know other people's thoughts or their experience with improving care in the clinical setting. If anybody would like to ask a question. Okay. If there's any questions, now is the time to post them, or if you'd like to put something in the chat box, now would be a great time also. Well, we'd like to thank you for attending this conference. WebEx, conference WebEx. And you can see there are a few questions here. If you would take the moment to answer them, we would really appreciate it. And I'd like to thank you and we hope you on our next WebEx. Thank you very much and have a great afternoon.